All right. So we're about to start the last session on a light topic, death and dying and organ donation and all of that. And you get a couple of pediatricians here. Norm Fost, whose pedigree includes Princeton, Yale, as well as Harvard, trained at Hopkins, but has spent most of his career at the University of Wisconsin, where he has been a pediatrician and director of the program in medical ethics. Spent quite a bit of time in Washington, has been very involved with aspects of public policy, the FDA Pediatric Ethics Subcommittee, National Academy of Sciences Committee on Guidelines for Stem Cell Research. He was a member of Clinton's Healthcare Task Force, along with Dan and others in the room. And then I'll introduce myself. So Bob Truog again. I'm a professor here at Harvard Medical School. I'm a pediatrician and an anesthesiologist, and I've worked for over 25 years in the pediatric intensive care unit at Boston Children's, and divide my time between there and the Division of Medical Ethics. As you're going to see, this is a bit of an awkward session in a way because Norm and I largely agree on the topic, but nevertheless our position is the minority view and quite provocative, and so I hope you'll find this interesting and perhaps enlightening as well. Norm.
Thanks very much, Bob, and thanks to Dan for inviting me to this incredible conference. It's daunting to have to give a talk after iconic figures like Alex Capron and Dan Hausman and all the iconic figures in the audience. I feel like Charlie Brown, when he and Lucy were lying on the grass looking at a summer sky, and Charlie said to Lucy, "What do you see, Lucy?" And she looked up at the clouds and said, "Oh, look, there's the bust of Beethoven. And look, over there, Charlie, there's Hannibal crossing the Alps." And she said, "And look over there, there's Christ in the Garden of Gethsemane." And she said, "What do you see, Charlie?" And he said, "Well, I was going to say a horsey and a ducky, but I changed my mind." After the talks you've heard today, mine is definitely going to be in the horsey-ducky category. It is a special honor, of course, to be part of this event honoring Dan Brock, and I don't want to skim over how much appreciation I have for him professionally and personally throughout my life. Whenever I have to give a talk or write a paper on something I don't know enough about, I just Google Dan Brock, and fortunately he's written about everything. But the thing about it is he's about the only person I know who I agree with about everything. So if I read something of his that I disagree with, it's about one of the rare occasions in my life when I think, gee, maybe I'm wrong about that, and I have to. So I don't know if our harmony on that is a tribute to his intelligence or mine, but I've certainly relied on him quite a lot. I can steal his ideas, but I've never been able to mimic his unbelievable ability to deliver the iron fist in the velvet glove, to tear ideas apart and maintain that wonderful smile. And I can tear people apart, but I'm not able to do it with the charm that that Dan does. And I just want to say personally, just getting to know him and being a friend, and at one point in his life, Dan sent me a note expressing some respect and admiration, and it meant as much to me as any such comment I've ever received from anyone. And so we don't do enough of that, and I thank you for that. I'm going to make some comments, having already said that Alex Capron is not but probably the iconic figure in legal bioethics, and certainly the grandfather of brain death and definition of death, and I think can personally take responsibility for saving hundreds of thousands, if not millions, of lives through what he did and helping to develop brain death statutes. And I don't think he did anything wrong. I don't disagree. As Dan Wickler said earlier, Dan Wickler and I and others, as you'll hear, disagree with conceptual aspects of that, and I think it's had some adverse effects in limiting expansion of organ donation. But I think it did the work that needed to be done at the time, and taking organs from brain, there's nothing wrong with taking organs from brain dead people with appropriate consent. So I'm not critical of the very important work that he did, but I think it's the conceptual differences that we have about it has thwarted expanding organ donation in a way that I think would be beneficial. So that's what the theme of this talk is going to be. So I recently had the privilege of getting involved with two patients at our hospital, one an 11-year-old girl with terminal brain cancer who herself wanted to be an organ donor. This was not just her parents. This was a remarkable person with an incredible sense of altruism who knew she was dying and asked if she could be an organ donor. And around the same time, within a week, we were involved with a 72-year-old physician who was quite competent, had ALS, was on some ventilatory assistance, and anticipating his death, also wanted to be an organ donor. Neither of them fit into traditional brain death protocols. Neither of them was going to die a brain death, and neither of them really fit into donation after cardiac death protocols. I'll say more about that for those who might be familiar with it. And they were not able to be organ donors. Even though the parents of the young girl had ardently wanted her daughter to do this, and her daughter, as I self, also wanted to do it. The requests were brought to the ethics committee, which I chair, and we actually came up with a way, which I'll describe in a bit, about how this could be done. There was unanimity in the ethics committee that this was ethically okay. Our hospital lawyers were okay with it. We couldn't get the transplant surgeons to go along with it for reasons that I'll explain, largely based on concerns about public opinion and violation of the dead donor rule. That is, the reliance that we've had in this country and elsewhere on the dead donor rule got in the way of helping these individuals be organ donors, and obviously in the way of recipients who might have benefited. So the key points I want to make are these, that the primary reasons for redefining death 40 years ago were based on false claims about the need for a redefinition as a way of improving organ supply. That the commonly used criteria for determining death are unreliable in the most important situation, namely when organ retrieval is contemplated. The dead donor rule is neither a rule or a sensible principle, and it's become a major contributor to the imbalance between organ demand and supply. Declaring death, in my view, is not necessary for ethically and legally sound policy in transplantation. That is, death itself is not important for sound transplantation policy. And finally, the part of the talk that links the most with Dan Brock's work is I'm going to suggest that changing our current practices, I think, is better done from the bottom up, that is changing practice and seeing how it flies, rather than to rely on a top-down policy, a statute, or a court decision, which is, as I understand it, Bob Truog's view, and so I hope he'll say something about his views about that. So it's the part of this that involves Dan's work is the wonderful work he's done on how policy should be changed in this specific area as well as others. So the reasons to change practice, obviously, are the growing gap between organ demand and supply. We could prevent many avoidable deaths. Transplant for kidneys certainly is less expensive than alternatives, probably liver transplant also. The present situation undermines family and donor preferences in grieving, like the two families that I mentioned. And conceptually, the present policy is based on biologically false claims. Bob Truog has used the word fictions, which I think is correct. He'll say more about that. And a confused ethical and legal principle, the so-called dead donor rule. So this is from 2005, but it just keeps getting worse. The dense lines at the bottom are the people who donate, and the curvy line is the growing, much more rapidly growing number of people on the waiting list, 10,000 or more of whom die each year, and who could live many more years of happy and productive life if there were more organs. That gap just keeps getting bigger and bigger. It's well over 100,000 now in this country. So I'm going to organize this around three questions. One, how do we know when someone is truly dead? And I'm going to suggest that the answer to that is we don't. Do we need to know when someone is dead for ethically justified organ transplantation policy? And I suggest that the answer to that is no. So it's like the teacher who said to the student, what is it with you, Jones, ignorance or apathy? And the student said, I don't know and I don't care. And the policy question is, do we need prior statutory or judicial approval to change the practice? And I'm going to suggest we don't, that we can change this practice soon and not wait for a legislature or a court to decide. So to recall the history, the reasons for redefining brain death as death of the person, when the Harvard Committee formally recommended that in 1968, there were three reasons that were stated. One, that there was a legal risk in discontinuing life support on brain-dead patients, as Alex mentioned. And while many people feared that, the legal risk was zero. There just never was and never has been any legal risk in discontinuing life support on any patient. There has never yet been a successful legal action with final appeals for withholding or withdrawing life-sustaining treatment from anybody in this country, as best I can tell. And there's a lot of people looking for it, and certainly not from somebody who's brain dead. There was some claim that respirators were making it difficult to prosecute criminal assailants. An assailant would shoot a policeman and he would be brain dead and be maintained on a ventilator, and the assailant's lawyer would claim, if you stop the ventilator, you killed him, not my guy. It was not a problem through theories of causal nexus. If you injured a person's brain in a way that inevitably and inexorably led to his death in the old-fashioned way, you were responsible for it. But obviously the major motive for this redefinition was to improve organ supply. And the Harvard Committee just sort of assumed that there needed to be this so-called dead donor rule, that donors needed to be dead to justify this ethically and legally, and therefore they had to come up with this new definition of death. The need for organs, in my view, did not require a redefinition of death. That is, to improve the supply, to keep up with the demand, did not require a definition of death, a redefinition of death, and as I said, in my view, I think it's impaired improving the supply. What's the evidence for this? First of all, Wisconsin was the last or the second to last state in the country in adopting a brain death statute, and for most of the last 4 decades has not only led the country but led the world in organ procurement rate. That is, Wisconsin has had an extraordinary organ procurement rate, much of it without the benefit of a brain death statute, and in fact most organs in Wisconsin's transplantation program come from patients who are not brain dead through DCD protocols, which were being used in Wisconsin long before anybody else adopted them. So the notion that you just couldn't have a good procurement rate without a statute was belied by that observation. Procurement rates, in fact, have never really depended on a statutory definition of death. There's some other evidence of that. We have within Wisconsin essentially a controlled study going on. We have 2 OPOs, one based in Madison and one in Milwaukee, both operating under the same statute, or non-statute for a while. And the procurement rate in the Madison-based OPO is hugely larger than the one in Milwaukee. So the statute is not the critical variable. The critical variables are who gets up earlier, who travels more, who establishes relationships with hospitals, who has education programs. The statute really was not the critical factor. There have been other statutory changes that have had little or no effect. Art Kaplan for years said we don't have a shortage of givers, we have a shortage of askers. And beyond all expectation, got a national statute passed, the required request law, in which now at every hospital, when a potential donor dies, the family has to be approached about donation. The effect of that on procurement rates was zero. It's just, there's more asking, but there's not more donating, because whether people donate, turns out, has to do with other things. And countries even that have presumed consent laws, that is, where you don't have to ask anybody, the organs belong to the state once you die, have procurement in most of them. The procurement rates did not change when those laws were passed, and their procurement rates are still well below Wisconsin's and other U.S. states. So presumed consent has had some effect in some countries, but for the most part has not had a dramatic effect. Well, Roger Dworkin, not to be confused with Ronald Dworkin or Gerald Dworkin. Roger was a lawyer at the Indiana University Law School. In '73 was the first, as far as I can tell, to start pointing out the problems with this redefinition of death. Dworkin said that the effort devoted to defining death is wasted at best, counterproductive at worst. The most basic question is, what difference does it make whether somebody is dead? That question places the issue of death into the only posture in which it can be relevant to the law, the posture of context or consequences. So Dworkin, very early on, saw that the issue isn't whether or not somebody's dead or not. It's a distraction. The issue is whether it's ethically and legally appropriate to take organs out of individuals and under what circumstances. This notion that defining death for transplant policy, and I want to repeat, for the first 30 or 40 years, due to Alex's work, it was very effective, but that it's now become unnecessary and, in my view, counterproductive. And many people, Bob says it's a minority view, but it's growing. Richard Delgado, who was actually at the University of Wisconsin Law School for a time, wrote about this in the 80s. I wrote about it in '83. Baruch Brody, in 1993, Bob has written eloquently about this with Franklin Miller. Starting in the 90s, the numbers now are actually too numerous to count. Everybody's getting on this bandwagon, and it's, I think it will eventually become a consensus. The confusion at the Harvard, within the Harvard committee that wrote the report is illustrated by this slide. The first line of this slide is the title of their article, A Definition of Irreversible Coma. That's a medical topic about which they had more than sufficient expertise. There were good data on what the predictors were of when a patient would be in irreversible coma. That was a great contribution. The subtitle was the report of the ad hoc committee of the Harvard Medical School to examine the definition of brain death. They seemed not to realize, they didn't mention in the article, that brain death is different from coma. Many people are comatose who are not brain dead, Terry Schiavo, for example. So the fact that brain death is something different from coma, they seem not to appreciate. But then they went off the deep end in the first sentence of the article, which said, our primary purpose is to define irreversible coma as a new criterion for death, now talking about death of the person, not realizing that death and brain death are not exactly the same thing, and certainly coma and brain death and death of the person are not the same thing. So they were jumbling up these different, although related, topics. Not surprisingly, because the committee wasn't constituted with the sort of people trained to think about these distinctions in this way, that is, philosophers and the right kinds of lawyers. There were many possible definitions of death floating around then and now. The traditional notion, so-called movie death, is when your heart and lungs stop breathing. They picked this one. Irreversible loss of cortical function, which Dan Wickler wrote about. Many people think is a more sensible one. That's when all the qualities associated with personhood are gone. In the UK, they don't care about any of those things. They care only about the brain stem. When you've lost the brain stem, which is the integrating part of the brain, the part that Alex is focused on, you're dead. You can have a functioning cortex, but if you have no brain stem, if the switchboard is blocked, you're dead in England. It could be loss of all biologic function, Beethoven-type death. He's really dead. It could be loss of reproductive function. That's what my biology teacher taught me in college, that what distinguishes living things from non-living things is the ability to reproduce. Not a great definition, because obviously a lot of us can't reproduce and we're not quite dead, but loss of genetic identity. Beethoven possibly could still be cloned once human cloning becomes possible and efficient. So is the new guy Beethoven or somebody else? So there were all these definitions. I've just listed them to point out that the Harvard committee didn't seem to realize. They didn't give exposition of why they picked the second one on the list, and why they preferred it to others. So this was an explicitly utilitarian policy, and they were honest about that. They didn't see themselves as making a philosophical discovery, although they seemed to think that they did. But they were about candidly achieving an important social purpose, and I think it was achieved without anything wrong happening. But a lot of the problems we're in now could have been avoided if they simply had stated that our goal is, quote, to redefine irreversible coma as a sufficient criterion with consent to remove organs for transplantation, end quote. That would have achieved the same result. We could have had statutes that supported that. It doesn't say anything about death, the definition of death, personhood, all these murky ideas. Maybe they thought that equating irreversible coma as death would be more easily accepted by the public, that it would go down easier to have this dead donor rule. I'll give you some evidence later that that turned out to be not true. But even that depended on two fictions. One, that patients who met the criteria were brain dead. And if you don't know this literature already, we'll go through it in a minute. But many, if not most patients who are now declared brain dead are in fact not brain dead. So we've been kidding people about that for a long time. And second, it depended on the assumption that the public cared deeply about this dead donor rule. And there's some evidence to dispute that. These two problems were quickly exposed by critical thinkers. So some of the problems are these. There is at the base of the brain something called the hypothalamus, which controls a lot of important things, water excretion for one of them. All of you make over 100 liters of urine a day, 150 liters, but you don't go to the bathroom every 10 seconds because your body reabsorbs 99% of it. It does that with the help of a hormone called antidiuretic hormone, whose control is from the hypothalamus, which is definitely part of the brain. The fact that many, if not most, patients who are called brain dead do not have diabetes insipidus, they're not peeing out 150 liters of urine, means their hypothalamus is working just fine. So if brain death means loss of all brain function, they do not have loss of all brain function. So calling them brain dead, which means irreversible loss of all brain function, is simply not true. Alex relied wholly on this notion that the brain was necessary for the, the functioning of the organism as a whole, but I think that's not true either. James Burnett, a very respected neurologist who's been writing in this field for decades, had reported one patient. So I mentioned Burnett's credentials because he's a highly respected and credible scholar and neurologist. Reported a patient reliably diagnosed by him as brain dead who lived for 14 years. Needed a lot of medical care. I don't think it was a great idea. Not saying anything about the ethics of it, but it belied the notion that without a brain, that the body could not perform its integrating functions. It needs help, like a lot of us do. A lot of patients need medical help to maintain these integrating functions, but you can do it without a brain. There were also problems just with ascertainment. Forget about diagnosis. In a study that Stuart Youngner did at Case Western Reserve, 20% of expert clinicians were applying the criteria wrongly. In a questionnaire study, for example, they said if you had a patient with anencephaly, an infant with no brain, no cortical brain at all, no cerebral hemispheres, they said that such a patient was brain dead even though he or she would be breathing on their own. So their brain stem was working, and yet 20% of and these were the doctors who were charged with diagnosing brain death. These were the neurologists and the intensivists. This is a note from a patient at our hospital. The patient is brain dead and the EEG is getting worse. So lots of competent physicians just didn't quite get it. Why is it important to know that somebody dies? As I said, one of the claims was it's necessary to stop treatment, which is not true. To prosecute assailants is not true. To remove organs, and I'll now turn to why it's neither necessary or sufficient to remove organs. To settle estates, to burial, it's obviously not sufficient for burial. Nobody would bury anybody with a beating heart just because their brain was not working, so it's not sufficient for that purpose. To practice procedures, believe it or not, there were hospitals that allowed students and others to practice procedures on brain dead patients, problematic for all sorts of reasons. So and their excuse was, well, the patient's dead and no harm can come to him or her. For some of us, that was neither necessary, certainly not sufficient for doing that. And it's not sufficient for grieving. For lay people whose loved one is brain dead in an intensive care unit, who looks like every other patient in the intensive care unit, blood coursing through their veins, pink cheeks, making urine, even capable of reproducing, telling them that their loved one has died is often not sufficient for them to grieve. So declaring somebody dead has various purposes, and one definition doesn't do it, and brain death certainly doesn't do it. Then along came donation after cardiac death, and this was the reliance on the dead donor rule created an even bigger fiction, and one that's more problematic. This refers to patients with severe brain injury who are expected to die after removal of ventilator support, in which there's unanimity among family and medical team that it's appropriate to stop life support and allow the patient to die, but with consent of next of kin, or in rare cases, the prior consent of the patient. The life support is discontinued in the operating room. So the family says goodbye, and the ICU, the patient is then taken to the operating room where the ventilator is stopped. Different hospitals wait different periods of time, and then what they're waiting for is for the heart to stop, and when the heart stops, they then declare the patient to be dead, not by brain criteria, there's not been time yet for the brain to die, but dead by cardiac criteria, which means irreversible cessation of cardiac activity. The heart is stopped, and the team says it's irreversible. What's wrong with that? Well, the patient's certainly not dead by brain death criteria, but they're not dead by cardiac criteria either, because many of these patients could be resuscitated. It's only been 5 minutes. You could get a fair degree of success with the team standing right there. Nobody wants to do that. It would be ethically outrageous to do it. But to make the medical statement that the patient has lost all cardiac function, irreversibly lost all cardiac function when resuscitation is possible, is simply inaccurate. This was exposed most embarrassingly in Denver about 4 years ago, in which they did 3 successful heart transplants after declaring patients dead by cardiac criteria. That is, these were, if Lewis Black were here, he'd be jumping up and down saying, you can't say that, you can't say that. That is, these were children who were, had brain injuries in which the family and the staff agreed treatment is not in the child's interest. It's time to let him or her die. With our permission, parents' permission, you can do that in the operating room. They did. They stopped the ventilator. They waited for the heart to stop, and then they took the heart out and transplanted it into 3 other children, and they survived long term. So to claim that there was irreversible loss of cardiac activity is just a flat-out lie. This reminds me of my Uncle Leo, who was a kosher butcher, and I asked him once, Uncle Leo, how does the meat become kosher? And he says, it's very easy. It happens between the slaughterhouse and the retail store. I just stamp kosher on it. What the doctors in Denver did was just stamp death on this patient's chart, saying he's dead, and the reason he's dead is because he's irreversible. Obviously, he was not dead by any criterion. I, by the way, don't think they did anything wrong. So I'm not discussing the ethics of it. I'm just discussing the conceptual confusion about calling somebody dead by cardiac criteria when their heart obviously works just fine. So we don't need to know the definition of death or even of brain death for responsible transplant policy. What is needed, as Roger Dworkin said a long time ago, is a policy on organ removal that's morally defensible, acceptable to the public, and avoids legal difficulty. What does morally defensible mean? It certainly doesn't mean unanimous. I mean, at the least, it would mean that thoughtful people, and I've listed a whole lot of very thoughtful people, all of whom agree. By the way, there's very few arguments on the other side of this, by at least in the scholarly ethics literature. And it should mean morally defensible, I think, as Dan has written, Dan Brock, public acceptance of the policy. This should not occur in secret or behind closed doors. And the question is how to get public acceptance or how to document it. And certainly morally acceptable should, I think, mean that it doesn't violate any existing laws, like homicide laws, for example. So to sum up what I've said so far, most brain-dead patients are not dead by generally accepted criteria for brain death. That is, even the brain-dead patients are not brain-dead. The cardiac patients are not cardiac dead. So that's most of our organ donors other than live donors. So we've been taking organs out of people who are not dead for a long time. Therefore, it seems that death is not really necessary for widely supported organ retrieval. Now, you may think, well, the public doesn't really understand what's going on here, but that's not true. So what is this dead donor rule? First of all, it's not a law or a statute or a court case. It's just something that's been sort of assumed to be out there. The only person who's tried to articulate it is our friend and colleague, John Robertson. And by the way, it's fitting that we're talking today about organ retrieval. I'm a pinch hitter here for John, who couldn't come because he's recovering from a lung transplant, which he received about 2 months ago, thanks to the work of Alex and others. And John has written what, in my view, is the only really well thought out paper on what this alleged dead donor rule is. And he says the essence of it is it's an ethical and legal rule that requires that donors not be killed in order to obtain their organs. Notice he didn't say that it says that the donor must be dead. It's just said that you shouldn't kill people to get their organs. So it should have been called the don't kill the donor rule. That might have been... So the basic fallacy of the dead donor rule is, first of all, it's not a rule, it's a guideline. It's usually ignored. As I've said, most patients from whom we take organs are not dead, so if it's a rule, it's one that's honored more in the breach than anything else. In addition, we have lots of live-related donors. These now are half of the organs that we retrieve in the United States. Obviously, they're not dead, so consent matters. We have live unrelated donors. We have friends, obviously, who donate. We now have stranger or so-called humanitarian donors. And by the way, 20 years ago, just talking about how policy evolves, if a stranger walked into the hospital and said, I want to donate a kidney, he would be sent to the psychiatry clinic, not to the transplant clinic. We have live non-consenting donors. Children for 40 years have been donors. And others have written about that. Courts have upheld that with appropriate protections. And then we have brain dead and DCD donors who are not dead either. So nobody on this list is dead. So the notion that we've needed a dead donor rule is belied by this list. Notice that these categories are expanding, and they're all expanding in a bottom-up way. There were statutes for brain death, due to Alex's work. But these other categories just evolved and became generally accepted by the public. There weren't any statutes that said children could donate or that strangers could donate. Because the professional views on these matters aren't fixed and the public views aren't fixed. The public responds to what happens and what they read in the papers and hear, and they're interested in how this is done, and their views are evolving. And a stranger donation is one example of that. So it's not surprising that the dead donor rule is not a rule. We allow invasions of the body for valid social purposes in other settings, but in the interest of time, I'm going to skip over that. So my claim is that there was no need for the dead donor rule, that we could have then and can now construct ethically defensible, publicly acceptable policy for removing organs prior to death based on traditional notions of consent and the best interests of the patient. Ethically defensible includes at least an expanding cadre of respected scholarly thinkers, which I've already mentioned. This whole idea got a boost last year when a transplant surgeon at Brown, the head of transplant surgery at Brown University, Dr. Morrissey, published an article in the American Journal of Bioethics proposing that kidneys could be removed from patients from whom DCD protocols were being anticipated. So what he was suggesting is, instead of taking the patient to the OR and then going through this ritual declaration of death, which is false, why not, before the patient dies in any sense of the word, remove one or maybe both kidneys? You would not die it takes days or weeks to die of renal failure. And the patient would not die of renal failure because within 24 hours the ventilator would be stopped in the clinical unit where the family can be close. The kidneys would be removed, and then the family, that's right, and the ventilator would be stopped and the patient would die in the unit. Other organs might be removed under a DCD protocol, but as a sort of first step, this is what he proposed. And this is what we had proposed at our hospital with the child and the gentleman with ALS that I mentioned. Morrissey pointed out that this would allow families to grieve in a peaceful setting. It would improve organ viability because you wouldn't have this 5 minutes even of no cardiac perfusion that occurs in the operating room. It could increase organ supply, and it would not cause the patient's death and therefore would not violate the dead donor rule. The patient would not die from removal of his kidneys. He or she would die from the cessation of the ventilator, which is the way he or she would be expected to die anyway. The focus would be on consent, ideally from the patient, but from surrogates who consent to termination of life-supporting treatment. And on notions of whether the patient's interests were harmed in any way. It would not hinge at all on whether the patient dead. There would be no claim that the patient was dead in any sense of the word. Some of the criticisms of Morrissey include these, that the complication rate would be higher in this population because these are sick patients, and some might die from the retrieval process. There might be an operative death, to which the response is, so what? I mean, this is consistent with the patient's preferences. The patient wants to die, or at least the family says our best guess is that dad would want to die in these circumstances. So if he dies of assuming it's a painless operation, his interests aren't being violated or his preferences. Bilateral nephrectomy could complicate comfort care of the dying patient. There'd be renal insufficiency, and maybe metabolism of drugs would be different, so dosing of drugs. But this is already true of DCD protocols in which the potential donor is given drugs that can be quite harmful to his or her well-being if long life is what you think well-being is about. That problem could be avoided by, at least in the beginning, restricting this to just taking out one kidney, which would not jeopardize the patient's management at all. This would require embedding the transplant team with the patient care team. There's supposed to be a wall between the transplant team. But this is true of DCD protocols and other live donors. That is, it's unavoidable that the transplant team has to interact with the donating family. The most serious obstruction to this is a very practical one, and the reason our surgeons would not operate on the two patients I mentioned is because it could harm a center's approval from UNOS. And the reason for that is because UNOS has a policy of attributing all causes of mortality within 30 days after a donation to the transplant team. That is, if I were to donate a kidney today to my wife, let's say, and then I got hit by a truck tomorrow, that would be called a donor death. And they would pay no attention to what the cause of the death was. It's a crazy system. It makes it easier to collect statistics, but it's completely misleading. Now, most donor deaths, which are very rare, are due to something related to the donation. In this case, they would have nothing to do with Morrissey's proposal. They would have nothing to do with the donation. They'd be due to the stoppage of ventilator support. But that's what they're afraid of, is seeing that you had deaths before 30 days, and you would then have a lot of them, and your approval, which means your certification, could disappear. So it would require a change in UNOS's policy. This, by the way, is in human subjects research, it's standard to have adjudication by some independent group, whether a data monitoring committee or some other group. When somebody dies in a human subjects protocol, we don't say, oh, it must have been due to the research because they died within 30 days of getting the research intervention. It's rarely due to the research intervention. And so some independent adjudication team makes a judgment. There's no reason that could not be done in transplantation. What does public acceptability mean? It might mean statutes or court cases, but as you all know, the legislative and judicial process is not a great way of judging public preferences. Legislatures are commonly unresponsive to public preferences. Since Gallup started polling, there has never been a time when a large majority of the American public did not want more stringent gun control measures, and it just doesn't happen. Legislatures are unable to deal with that. judicial and legislative process can obviously produce immoral policies such as slavery, involuntary sterilization. So the presence or absence of judicial or legislative approval doesn't really shed a lot of light on whether it's morally acceptable or not. Wisconsin has a particularly wacky bunch of end-of-life decisions by our Supreme Court, which are pretty widely ignored. I mean, they're so out of step with the overwhelming public opinion about end-of-life care that they have almost no moral force at all. Public acceptability could mean the absence of litigation. Robert Byrd has suggested in his book, Taking Care of Strangers, that instead of having statutes about end-of-life things, we should just let doctors do what they do and let the civil and criminal tort liability and criminal law deal with it, and they'll get the message pretty quickly as to what's acceptable and what's not. I mentioned in Wisconsin we've had no litigation and no complaints despite a DCD protocol that takes organs out of living people in the absence of a brain death statute. There's a absence of complaints doesn't mean people are approving. They might not know what's going on, but there have been efforts to get the public to get upset about this, and it's really hard. Gina Collada wrote a front-page article in the Times after a big conference at Pittsburgh about their DCD protocol, and she thought she was going to get deluged. She got 3 letters, and they were on trivial topics. More significantly, 60 Minutes did a real piece of yellow journalism on the University of Wisconsin DCD protocol. I mean, they intended to make it sound like murder. They quoted Art Kaplan saying it was murder. They did everything they could. We were very distressed about it. We thought it was going to lead to a tremendous reaction against the program. We had a phone bank of 10 people, including myself, the night of the broadcast. The total number of phone calls was 0. There was not a single phone call. I don't know if the public was confused or watching a football game or what, but and the Denver DCD protocol, which you think would be outrageous, I mean, they killed 3 children. They took their hearts out, their beating hearts out, and stamped death on them and saved 3 other lives. As I say, I don't object to the protocol, but you'd think if anything would rile up the public, or if somebody who wanted to make a lot of hay out of how cannibalistic transplant surgeons are, that would have been, I'm aware of no public reaction. It's not a secret. It's been widely reported. Surveys, of course, are of extremely limited value. Dan Hausman has written eloquently on this in several places. The public is, of course, not informed when they take these surveys. Hypothetical preferences may not correspond to what they actually do. It's illustrated in this field. People who say they will donate don't. There's 3 times as many people who say they're willing to be an organ donor than who sign a donor card. The majority obviously can be wrong on important moral issues. And many people don't want policy based on surveys. They want it based on more informed judgments. Jeff Richardson, as Dan pointed out in one of his papers, called this the abdication hypothesis. Many people prefer that decisions be made by experts, particularly in healthcare. And Richardson reports on surveys in Norway and Australia showing support for maximization of lives saved over specific public preferences about specific policies. I've already mentioned that Wisconsin has had wide public acceptance of its program despite having no brain death statute and a very controversial DCD protocol. I've already mentioned that. Stuart Youngner did a survey in Ohio, a multi-ethnic, multi-socioeconomic survey of 1,000 people in which he gave them 3 paradigm cases about organ removal. In short, to summarize just some of the key findings, most people in that survey thought it was okay to take organs from brain-damaged patients, that is, relatives of theirs, even if alive. 75% supported organ retrieval from a relative who was in a persistent vegetative state, who meets no criteria for death. 55% thought such a person was dead anyway. That's a common statement when somebody's in a vegetative state like Terry Schiavo. And even 55% thought that a relative who had had a bad stroke from which he or she was unlikely to recover, that it might be okay to take organs out. So I'm not saying the public's right about this, but they're way ahead of the transplant surgeons. They want a much more aggressive, or they're supportive of much more aggressive policies than the transplant surgeons. We did a study some years ago of our adult cystic fibrosis patients. The kidney and the brain are about the only two organs in cystic fibrosis that are not involved. Most of them die with normal renal function. And we asked them, how would you feel about having, I should say, by the way, that patients with cystic fibrosis know when they're going to die with a fairly high degree of predictability. They certainly know the year they're going to die and when it gets close. And they've been thinking about this for 25 years, so they know what's going on. So we asked them, when death is close, how would you feel about donating a kidney before you die? A third of them said they would be happy to do that. A third said maybe, and they just need to think about it. And a third said they weren't interested. And none of these patients now can be kidney donors because of the dead donor rule, and they're not accepted as stranger donations because the donation might accelerate their death. The operative procedure, they might have trouble coming off the ventilator. But these are patients who would make this decision. These would be fully competent patients, like our patient with PVS, who would say, I want to do this, and if I wind up dying from the procedure, I accept that complication. So the public is no more confused than the physicians at Case Western Reserve. They're far ahead of the academic and the policy people. They appear to be tolerant of more expansive organ retrieval policies. Finally, I just want to say something about this bottom-up approach and comment on two very important papers by Dan Brock, and I think that I'm not going to be violating anything that Dan believes in, but I'm looking forward to his policies. It would trouble me greatly if I were on the wrong side of this issue. So policy can be top-down or driven by practice. Transplantation generally has been bottom-up. The brain death statutes was certainly statutory in the beginning, but all the changes since then have been bottom-up, as I've mentioned. Anencephalic donors, in fact, at Loma Linda for a time were not brain dead, were used as organ donors, and there was a physician in Ohio who did one transplant from an anencephalic donor with no screaming or yelling and no prosecution. So Dan has, in writing on this, and what he was writing about, to be accurate here, was it was on the determination, on the role of the public in this definition of death. He wasn't writing about ante-mortem harvesting, which I've been talking about here. Dan said that there should be a presumption in favor of democracy, which I agree with. He was responding to proposals in this symposium about this topic. About Robert Burt, for example, suggested maybe we should just keep these fictions under the radar. Maybe we shouldn't be having conferences like this even. Maybe we shouldn't be telling people about this because it would just be upsetting. And Dan wrote that he really didn't think that was a good idea, that if the public, there should be openness and transparency, that there's a duty to be truthful to the public, and as he said, there needs to be at least indirect public participation. But I understood his paper to at least be consistent with a bottom-up kind of policy as long as it was open and transparent. I didn't see in that article anything that said we had to have a top-down. Top-down is one way of getting public input, but not the only way and maybe not the best way. There are many other examples of bottom-up policy in very controversial areas. Conception for donation, I don't want to remind Alex, but when the Ayala family in California created a baby for the explicit and sole purpose of being a bone marrow donor to her dying sister, everybody in the country was against it except some of us. But Alex, I remember, was very critical of it. The younger Ayala sister just graduated from one of the California universities. They're the happiest family in the United States. The end doesn't justify the means, but this is something that was opposed by just about everybody. Today, it is standard practice. Every transplant center in the country has conception for donation, sometimes through pre-implantation genetic diagnosis, but sometimes even selective abortion of HLA in unmatched fetuses. Other reproductive technologies, IVF was opposed by virtually everybody. When Louise Brown was conceived 30 plus years ago, it's now wallpaper. I mean, everybody knows somebody who's born by IVF, and even Leon Cass, the president's advisors, who was stoutly opposed to it, has come around and says, I guess it's okay. By IVF? Is that right? That's interesting. I didn't know. Even reproductive cloning, when Dolly the sheep was born, 99% of Americans were against cloning of animals. And in one recent survey, 50% thought that human cloning, human reproductive cloning might be okay in some circumstances. They were at least open to thinking about it. So the public changes. In summary, brain death statutes, in my view, were unnecessary. They were valuable and they achieved an important purpose, but I think that purpose could have been achieved in a different way. They certainly weren't necessary to allow doctors and families to discontinue ventilators or to resolve homicide cases and not to remove organs. These statutes, in my view, were beyond the competence and the role of the Harvard Committee and the legislators who adopted their recommendations. Brain death and cardiac death have been based on false biologic notions, what Bob has called fictions, correctly so. Neither organ has irretrievably lost function in most cases. Organ retrieval, in my view, should be based on traditional concepts of consent, the patient's interests, and public support. At least one kidney could be removed before discontinuing life support without causing the death of the patient. Once that got accepted, then 2 kidneys, then maybe a lobe of the liver, and if the patient consents to all of this and he or she's expected to die anyway, I think it could. We're talking about tens of thousands of organs. That curve that you saw could be closed, not closed completely, but substantially narrowed. In conclusion, we don't need an answer to the question of whether or when the patient is dead. All we need, as Dworkin said, is to reach consensus on when it is ethically and legally acceptable to stop treatment, take organs, settle estates, or bury people. Declaring death is useful for grieving, but for that, the traditional notion of death, when the heart stops, that's when families grieve, and brain death is not necessary for that. Thank you.
Well, as I said, it's a little challenging to give a commentary about something that I completely agree with. So I'm going to just make a few, actually I'm going to make three points here. First of all, some of you might be wondering, I don't know if it's entirely clear from what Norm said, if it's not the dead donor rule that justifies removing organs for transplant, what is it? And I would argue there's 2 things that make it permissible, is that the person is imminently dying, is near death, so that they're either going to be dead shortly without being an organ donor, or they're going to be dead shortly having been an organ donor, so that it doesn't really change their outcome in any way. And then the second part of that is consent. Now, the provocative part about Norm's talk for me is the idea that this could be done bottom up. And I'm on the ethics committee for UNOS, the national organization that oversees transplant. And I can tell you that in our meetings, there's a lot of sympathy towards your view, my view, really, I think the view of many people, as you said. But very much the dominant opinion has been that this would require a change in the laws, that it could not be done in a bottom-up sort of way. And so that's where I think your talk is particularly interesting and helpful. But I do want to, my first point will actually support your perspective. Professor Capron spoke this morning about the case of Karen Ann Quinlan, a woman in a persistent vegetative state. Her parents requested that she be taken off of the ventilator. The physicians refused because they said that to take her off of the ventilator would make them the proximate cause of her death. That would be murder. Now, in fact, the judge in this case really agreed with him. She wrote, "It seemed to be the consensus not only of the treating physicians, but also of the qualified experts who testified, that removal from the respirator would not conform to medical practices, standards, and traditions. It would be killing her." So how was it that the Quinlan court decided that it was nevertheless okay to take her off of the ventilator? Well, it's because, she wrote, even if it were to be regarded as a homicide, it would not be unlawful. Now, of course, this is one judge writing in one court case, but it's an iconic case for us. And it's a judge who said, you know, whether it's killing or not, that's not the important question. Whether it's lawful or not is going to hinge on other things, as I think you described so nicely. The second point I want to make comes from the fact that, if you're going to do bioethics, you've got to be open to criticism. But my views around this in particular have led to hundreds and hundreds of very aggressive emails of people who have been highly critical of what I've been saying, that you're promoting vivisection, tearing organs out of people, being a vulture. And I don't feel that it is that. Surely there would be lives saved from additional organs. But I want to emphasize the flip side, and Norm commented on this. And it comes, I'll just tell briefly a little story of a child that I was involved in the care with here at Boston Children's Hospital. This was an 8-year-old a few winters ago who was out with her mother while she was snow blowing. And the child was playing and got her parka caught up in the snowblower, and it strangled her, and their mother was unable to relieve the tourniquet before she had suffered severe brain injury. So she was brought in, and very quickly we realized that she was not going to recover, but she did not meet any potential pathway for organ donation except for donation after cardiac death. And she went to the operating room. She had life support withdrawn in anticipation then of removing her organs once her heart stopped, but her heart didn't stop. She continued to breathe, and enough time went by that we had to take her back to the intensive care unit, where she died about 12 hours later. So Darshak Sanghavi, who's a physician journalist, wrote about this case and some others in the New York Times Magazine a couple of years ago. And in speaking with her father, he wrote, Paul, that is her father, has some difficulty understanding why, if Jaden was going to die anyway, she could not have been put under general anesthesia, undergone surgery to donate her organs, and then been declared dead. So Darshak says, well, the reason they couldn't do that is because it wouldn't have complied with the dead donor rule. They would have been removing her organs before she was dead. And he responded, well, there was no chance at all that our daughter was going to survive. I can follow the ethicist's argument, but it seems totally ludicrous. So, this is really, I think, an issue from the perspective of patients and families, too. It's not just about getting more organs for donation. For this family, the first loss was of their daughter and the decisions that they made to withdraw life support and allow her to die. But then they underwent a second traumatic loss when their hopes for her being an organ donor also could not be fulfilled. The third and last point I'd like to make has to do with the question, if Norm is wrong and if this can't be done from the bottom up, is there some way that we can approach this without wholesale changes in our homicide laws? And I've worked with Frank Miller and Seema Shah at the NIH. Seema's a legal scholar, around this concept of legal fictions. And first of all, I want to say that the idea of legal fictions is not pejorative. There's a large literature around this. So, if your vision is less than 2200, you're considered legally blind, even though we know you're not necessarily really blind. If you've been missing for 7 years, you can be considered legally dead, even though if you show up at 8 years, it's not like people think you've been resurrected. But so there's a big literature around this, and we were looking at, could we see the development of legal fictions as a halfway approach? And I'll mention this briefly, there's two types of legal fictions that we're going to talk about here. One is status fictions, which applies to situations where two conditions, A and B, are clearly different, but similar in certain ways. And one that's very common in the law is to see corporations as persons. Obviously, corporations are not persons, but they're treated in the law as very similar. The rationale is that it avoids the need to reinvent the wheel if the similarities between A and B make it sensible to use the same law for both. The dangers is that the analogy may be extended too far, and this was the issue in Citizens United, where there was the issue as to whether the free speech rights of persons could be applied to corporations. So could brain death be regarded as a status fiction in this legal sense? Brain dead patients are not medically dead, but do they perhaps share enough features with dead patients that they could be treated the same as being dead with regard to organ donation? So that would be one way of making a legal approach towards allowing donation from patients who are brain dead while recognizing the truth that they aren't dead. And then a similar approach would apply to DCT donation. This is an idea that's based on anticipatory fictions, where A will imminently become B. And an example in the law is where there's an anticipatory breach of contract. So you and I have a contract. It's very clear to you that I'm about to break that contract, and I have every intention of doing so, but if I'm allowed to do so, it's going to be harmful to you. And so a judge will step in and say, I'm going to intervene now, even though the contract has not yet been broken, because if I allow it to be broken, there will be harmful consequences. So how could this apply? Could organ donation after circulatory death be regarded as an anticipatory fiction in this legal sense? And the idea here would be that loss of circulatory function in DC donors is not yet irreversible. They're not yet dead. But they will soon meet this criterion. Within another few minutes, they are going to be dead. But if we wait that long, then their organs will not be usable for transplant. So can we create this legal fiction here? Now, I'm not sure I think that this is necessarily a good idea. What I like about it is that it allows the life-saving process of organ donation to go on, but it introduces an element of transparency and honesty that is not there right now. It could be a way of introducing the public to the idea that there's nothing illegal going on here, nothing shaky. These are legitimate, justified actions, and sort of a halfway step towards ultimately recognizing that we don't need our dependence on the dead donor rule at all, and then we end up where Norm would suggest taking us much more quickly. So with that, I'll stop, and why don't you and I take a few questions?
Well, thank you both for excellent remarks. I had a question which I could address to both of you, although Bob did start to articulate some criteria, but Norm Fost did not. And I wonder if you could say what you think would make the taking of organs justifiable in these contexts, and what the criteria would be, because that has always been the sticking point. And if you think a bottom-up strategy would work, presumably it's because you think you could, in retrospect at least, justify whatever came out of that strategy, or only some of it, and if so, which part and which ways of taking organs would matter.
Well, as I think we both said, the principles would be the very familiar ones of consent and acting at least in a way that's not contrary to the interests of the patient. So to take the specific examples, our 72-year-old gentleman with ALS who's clearly competent, and it's just a live stranger donation. He'd be no different than anybody else who walked in the door, except for the fact that he'd probably die within days of the donation, but he accepts that. The notion of getting some sort of intervention in your body that can kill you happens every day in a hospital. People consent to operations that have a 50% mortality rate because something good might come out of it, and they may have a 90% chance of the operation killing them, but something good may come out of it. Usually the something good is I may go on living and go home. In this case, the something good is I can give my organs away, which is what I want to do. And if I die, that's a good thing too. That's what I want to have. So that's a consent model. I think surrogate consent can suffice for that also. Parents, we have surrogate consent models for child donors, children who are healthy and who are expected to survive the donation. But a child who's terminally ill, a parent can, it seems to me appropriately, and parents consent to non-therapeutic research on children also, obviously. Sure.
Because it doesn't seem that, suppose I want to die and could step in front of a bus, kill myself, and so I say, well, I want to die, but I'd rather do some good while I do it, and so I consent to giving my organs tomorrow.
So,
why wouldn't that?
So let me respond to that, because in our book, Frank Miller and I thought a lot about that. And we put in a rather, I'll admit, ad hoc safeguard, which is that the patients must be dependent upon life support. And this would block at least people who choose a suicidal donation. Getting back to what Norm says, I mean, the principle here is that we're not harming these patients by removing their vital organs. They are going to be dead shortly anyway in any case. They've made a decision not to want to be supported on life support. The question is whether they're going to donate their organs while they die or not. And this wouldn't be for everyone, of course, and that's where the consent becomes so important.
That's the constraint you would pose in this discussion, but I'm wondering if there was a bottom-up strategy and people said, well, that shouldn't be our constraining factor. How would you respond to that?
Yeah, I mean, one of the criticisms is that this proposal doesn't go far enough, that there should be lots of other people who aren't near death who should be allowed to do this. Well, first of all, other people can donate one kidney, so I mean, and our cystic fibrosis patients they're not being utilized enough. But I think in terms of public acceptance, being respectful of Dan's caution that, you know, the public should not only know what's going on, but see it as acceptable. I think if you limited it to get that level of buy-in in the beginning, I think if you limited it to terminally ill patients, people would understand that nothing bad has been done to this person, nothing contrary to his or her interests or contrary to what they want. I think limiting it to one kidney in the beginning is a way of getting what I've proposed to our surgeons, and they're quite interested. And if the UNOS would simply not blame them for the death that's going to occur in the next 24 hours, they might very well be willing to go ahead with it. If somebody published a series of 5 or 10 cases of unilateral kidney donation one day prior to death in a patient for whom death was anticipated, I think no law would be violated. I don't know of any law that would be violated. I don't know any ethical principle that's violated. It doesn't even violate the dead donor rule because it wouldn't kill the patient. And it would give other transplant centers some encouragement. Oh, they did it there, maybe we can do it here.
Yes,
Hi. So in thinking about the ad hoc committee, the Harvard ad hoc committee, I always was struck by the ease at which they did this conceptual slide between definition of death and criterion for death, right? So you would, I think, need first the definition of X to then know what the criterion for picking out the presence of X is, upon which then you would then make a decision about which criterion is really the better one. So in this here, your legal fiction is the halfway approach. I'm trying to figure out, so where does that sit? I mean, that seems to be more on the side of maybe picking out something like the sufficiency conditions for going ahead, right? So you're not quite doing this kind of sliding that I think the ad hoc committee was doing. Could you maybe comment a little bit more on that?
Well, I would just say that we're saying that the legitimacy does not depend on the dead donor rule. The legitimacy depends on these other factors. And then we would say that patients who are currently brain dead donors and patients who are currently DCD donors, they fit in under this legal fictions approach because they meet what we would regard as the relevant ethical criteria. But it's a halfway step towards weaning us off of the dead donor rule, I would say. Again, the fact that it is a halfway step makes me somewhat cautious to recommend it. I'm rather partial towards norms, let's just call a spade and go all the way.
Yeah, the part that makes me uneasy about your last slide there, Bob, was that it seems to me it's caving into the dead donor rule. You're suggesting that we should be able to call people dead even before we stop the ventilator because they're as good as dead. They're on their way to being dead.
That's what it is.
That's caving into the notion that it's really important that people be dead before we take their organs out.
Fair point. Nick?
First, thanks for the incredibly lucid presentation of this topic. I've been talking about this for 5 years, and I don't think I've gotten anywhere close to as well crystallized an argument as you make. One comment is that taking one kidney is not a great victory because kidneys are notoriously pretty sturdy and tolerant of warm ischemic time. So getting one kidney out a little earlier than others, I'm not sure that's a major step on the road towards the bottom-up victory. When I've talked at other institutions about this, the biggest pushback is from, as you alluded to at Wisconsin, the surgeons, because they're afraid that if we really declare that the emperor has no clothes and brain-dead people aren't dead, then they lose their pipeline. That pipeline that they can at this point count on. They're afraid they'll that'll scuttle all organ donation because nobody's really dead. And that was actually reinforced when I spoke with Alex Fraser as legal counsel at New England Organ Bank about this, and she said, because I was proposing that organs could be removed under anesthesia in a DCD scenario, and she said, well, you can't do that, that's murder. Comments?
On your second point, there's no reason to stop taking organs from brain-dead patients, and if you people want to go on pretending they're dead and writing the patient's dead by statutory criteria, I don't have any objection to that. It's, I mean, the honesty is out there, the articles are all there, there have been public symposia and so on. So I'm talking about ante-mortem donation, but not stop. There's no reason to stop post-mortem donation, whether the post-mortem donation is phony DCD or phony brain death. So since that's widely accepted by all means, so when you say there's no added value to taking one kidney, I mean the CF patients, for example, there's no CF patient that's donated a kidney ever, to my knowledge, and I don't see any reason not to start that tomorrow, even though the operation may accelerate their death. So I think that's 5,000 deaths a year. That's 2 kidneys. So, and then there's the ALS patients and lots of others. So I don't know whether the upside is many thousands or a few thousands or a few hundred, but every one is a benefit for the donating family and for the recipients, obviously.
Francis?
Yeah. So my primary concern is the view that the way you put it, Norman, the public is ahead on this issue. The fact that the public accepts a more extreme view than you propose, and your proposal would be encompassed by their extreme view, doesn't show that they're ahead in a good way such that you should affiliate yourself with their views. If they think that you can take organs from patients who've had strokes, or prisoners, or severely mentally ill people, right, that's certainly ahead of you, but you don't want, presumably, to think that what they're saying is correct. All right. So there was that part of your talk, I think, weakens your position because you're affiliating yourself with views that may not ultimately be morally defensible. I was really worried about that, okay? And I would try to distinguish your view from those in the case where you can't morally justify them. I think that's very important. Minor point, just a philosophical point about the notion of harm. 2 points. You mentioned, Norm, that doctors said the patient is dead. We can't harm them anymore. Many philosophers think that people can be harmed after their death. If I destroy all your publications, spread rumors about you, chop up your body in a way that you wouldn't have wanted, not only am I disrespecting you, people will say you can be harmed after your death. And that's something that doctors should know about, I think.
Well, that's the key element that consent plays, right?
Well, consent is, I don't know, if that's more like respect. I'm talking about actual harm, doing you harm, okay? Because I could get your consent to the destruction of all your written work and all your labors, and I think I would have gotten your consent, but I still would have harmed you, right? Okay. The other thing is that your notion of harm, in the case where you take out both kidneys and you do something to the person, remove all their organs, such that they will die from that, you say, we're not harming them because they would have been dead anyway. That's only on what's known as a comparative view of harm, namely, are they worse off than they would have been? But there's what's known as a temporal view of harm, namely, are they worse off than they were? And in that sense, you are harming them, because even though someone else would have shot you, if I shoot you just at the same time, right? I'm the one on the temporal view of harm, made you worse off than you were. Now, it may be morally insignificant that I harmed you because somebody else would have done it if I hadn't done it, all right? But it may not be morally insignificant because there may be agent-relative concerns such that I did it as opposed to somebody else doing it. So I think you have to be just a little careful, because philosophers, you're a philosopher, will look at your, what you're saying, to distinguish the comparative versus the temporal and think whether you think the temporal, is morally insignificant. It's correct, but it doesn't matter that you harmed somebody. So I think that some of those issues struck me when I listened.
Thank you.
Thank you, Francis. I have 2 comments to your cautionary note about the public may have crazy views about this and I shouldn't align myself. 2 points. First, and I'll be more careful in future presentations, the purpose of reporting on Youngner's survey is in response to our surgeons who say, if I do what you're proposing, Norm, the public will freak out. They're not ready for this. And I think that's not correct. I think the public would be most of them at least, would be quite pleased. But second, I don't know that it's such a crazy view. That is, let's take the 55% that said, if my father has a bad stroke, I think at least it might be okay to take out organs. Suppose I wrote an advance directive that said, if I have a bad, and this is pretty close to what my advance directive says, if I have a bad stroke, such as that, let's say I can't communicate anymore and I can't take care of myself, I'd rather die. So I want everything stopped. I don't want to be 2 days in the ICU. I don't want 1 day in the ICU. If it's a bad stroke and there's a lot of brain damage and competent neurologist says he's not going to be able to control his own life anymore, I want treatment stopped, all life support stopped. If it's food and water, that has to be stopped. And that's fine. Everyone thinks that's a perfectly sensible advance directive. Not everybody wants that, but nobody thinks there's anything problematic about that or implementing it. So what is Ed's problem if I put a new sentence in there that says, and before you stop the ventilator, I want you to take my kidneys out? What's crazy about that?
No, but I was talking about people who don't put the word consent in. Did you have the word consent in there? I thought
Yeah,
they
no,
said you can take organs from people who've had these strokes, as if they were disposable people, independent of any prior or designation by them that they wanted their organs taken.
The survey.
Maybe I've misunderstood.
No, the survey didn't ask that. It didn't drill down. But it just what the survey shows us is that a lot of people think when the loved ones had a bad stroke and they're going to die, that taking, under some circumstances, or taking organs out would be okay. I think adding consent to it makes it really okay. But then that would leave the last barrier, which is what about surrogate consent? That is, what if I hadn't put this in my advance directive, but my wife said, I know Norm a lot. I know not only that he would like to die under these circumstances, but I've heard him give talks and write articles about this. I'm pretty sure he would want his organs taken out also.
Right. But the way you presented it, and I say this just for sake of presentation, for strengthening your argument, you just said most people, or 55% or whatever,
Right.
say if he's had a severe stroke, you can take his organs. And that sentence alone makes it seem like they think people who have had this are disposable. They're disposable,
I appreciate
essentially.
that.
And if you don't want, and I don't think you should want, to affiliate yourself with that
I agree.
view.
That's very helpful. Thank you.
So being my own timekeeper, how about we'll have two more comments and then we'll move on.
Thanks, Bob. So thanks for two very interesting presentations. Both of you have emphasized the importance of transparency and consent. And I wonder if we could just think a little more concretely about how we would legitimately feel that we have discerned public acceptance, and what would need to be said in consent with individuals and families about these practices. So there have been a couple of studies, and they are impressive, the one you cited in the Ohio study. If you're just thinking of the population of Wisconsin, maybe I'll just pick on you, Dr. Fost, first, because you're right, engaging in the practice. You know, how much needs to be in the news? What kind of opportunities for people to actually know not only what's being done, but what the debates are by people who really are thoughtful and have looked at it for a long time? You know, what should be said to the public? And then secondly, when you've got a family and you're getting individual consent, what do you need to say about some people actually think this is illegal or, you know, immoral or whatever?
Yeah, well, two answers. First, you can't do any better than 60 Minutes. At the time, that show was shown, it was one of the 5 most watched shows in America. So millions and millions of people saw it. And that, I assume, includes a wide range of people with religious and other views. And none of them raised the fuss. So absence of complaints doesn't mean that. But we don't need to take surveys on everything we do. That is, as I mentioned, we made advances in reproductive biology, and it seems okay. Nobody's petitioning the government. Nobody's blockading the hospital. People aren't going to the legislature. They are, but they're not getting very far because there's not much support. So, but in this, that 60 Minutes thing was 1997. Already the number of news outlets that we have, I mean, I guarantee you if the University of Wisconsin published an article saying we took 5 kidneys ante-mortem of patients who were going to die anyway, it'll be all over the cable channels and everywhere, like the Denver thing. And if the Denver thing didn't upset people. So I don't have a specific plan. I think the news media is ravenous enough that I have no doubt that there'll be wide public awareness of it, and we'll see what happens.
So would you wait for that, or would you actually release something, trying to frame it in a way that you think
If
would
UNOS
enable
would
people to
endorse it, if
understand?
UNOS would endorse it, I think there are surgeons now, and Morrissey is one of them, who I think would do it and would publish and do it openly and publish an article about it and present it at a national meeting and do interviews with the press and take on what.
Yeah,
take
but,
whatever
so,
goes.
but in all fairness, Norm, if UNOS endorsed it, they would endorse it, and they would super emphasize that it complies with the dead donor rule. And so that it could actually be
Well-
somewhat counterproductive, because it could
Well-
actually reify the dead donor rule as the real
Yeah,
line that cannot be crossed.
Morrissey's proposal is compatible with the dead donor
Exactly,
because
so, but
it
it-
doesn't
it-
kill anybody and nobody's dead.
But you are thinking about using it as sort of a stepping stone towards proposals that clearly would violate the dead donor rule. So I'm wondering about the strategy of it.
Could you just speak to the individual consent? You're doing it now. What kinds of things do you say to families, or do you think need to be said to families about what might
Well,
be debatable here? Because they might later hear about the debates and think, oh, what did I do?
Well, I think we need to return to our CF population and survey them again, and this time with the surgeons' agreement, if the surgeons were on board with it, saying, you know, Miss or Mr. X, I know you're going to, as you know, you're probably going to die in the next few months. Would you be interested in talking about organ donation? And here's how it would happen. And is that responsive to your
Well, I
question?
just wondered if you feel that people need to actually know what the debates are around
yes.
something which many think is illegal and others would feel is just a great idea for pushing the envelope.
Yeah, I don't know what would be illegal about ante-mortem donation one day before death. It would be
Yeah.
novel, but I don't know anything. I can't, maybe Alex or somebody can, Alex says no. I can't think of any law that's violated by that.
Okay, thank you.
Thank you.
I'll cede to the next speaker.
All right. And lastly, Marion.
Hi, I appreciated both of the talks. I wanted to raise one question about the problem, Norm, that you're both dealing with here, i.e. the gap between donors and recipients who need organs, and say that I'm struck that bioethicists are not or focusing on this highly technological solution to narrowing the gap, and that I don't think we're talking enough about reducing the need to transplant organs and talking about excessive use of nonsteroidals and that are leading to kidney failure and the kinds of situations that the epidemic of renal failure that we're seeing as people grow older, and whether we think we should be transplanting people as we see this great epidemic of renal failure as people get older. And I think if we don't think about that side of it, we tend to ignore the distribution of who's donating and who's receiving, and what the distributional effect is there. I mean, we're getting a lot of our donors from young, healthy people who've had gunshot wounds and people who've had motor vehicle accidents, and we could be saving a lot of lives without having to do this highly technological surgery and then immunosuppression, and I just want to put that on the table.
Yeah, I'm not enough of a nephrologist to know what are the most easily preventable causes of renal failure, but I'm suspecting that diabetes is going to be high on that list, and the obesity epidemic in childhood that we're seeing now is going to make the slope of that curve 20 years from now go up even more rapidly.
Okay.